Our morning sessions will be kicked off with our keynote speaker, Dr. Monique Rainford. And at this time, I would like to introduce Dr. Sherelle Barber, Assistant Professor of Epidemiology, Director of the Ubuntu Center on Racism, Global Movements, and Population Health Equity at Drexel University Dornsife School of Public Health. Dr. Barber will be the moderator for our keynote session. Dr. Barber, please come.
All right. Good morning, Mississippi. It is such a blessing to be here and to have the honor of both introducing our keynote speaker for this morning and moderating this session. So my name, again, is Dr. Sherelle Barber. I'm a social epidemiologist and have strong ties to the state of Mississippi and Jackson very specifically. Dr. Monique Rainford. Dr. Monique Rainford is an obstetrician and gynecologist, author, public speaker, and expert in health disparities affecting Black women in America. She is a graduate of the University of Pennsylvania and Harvard Medical School, where she has been recognized for her outstanding academic performance, having been awarded the John Rushforth Award for Academic Excellence and the Robert H. Ebert Award in Primary Care Medicine from each university, respectively. She completed her residency in obstetrics and gynecology at Georgetown University Medical Center. She is also a diplomat of the American Board of Obstetrics and Gynecology and a fellow of the American College of Obstetricians and Gynecologists. She currently serves as an assistant professor of clinical obstetrics, gynecology, and reproductive sciences at Yale University School of Medicine, in addition to women's health consulting through her company, Well Incorporated. She will complete her MBA from Yale University in 2024. Dr. Rainford's writing has appeared in multiple publications, including the Hartford Courant, the Baltimore Sun, Afro Elephant Journal, Medscape, and Kevin, MD. She has appeared in the media, including CBS Baltimore, ABC, 2 Baltimore, and she is the author of the book, Pregnant While Black, Advancing Justice for Maternal Health in America. Please join me in welcoming Dr. Rainford.
Dr. Barber, thank you for that kind introduction, and I really want to thank the Glenn Family Foundation for inviting me to be here. It is a pleasure and an honor and a privilege. So I actually didn't figure out how I'm going to advance my slides, but I see it now. So I think I'm going to start a little bit about the story of how I got to be in health equity, or how I decided to go into health disparities. Why? So I was actually born in Brooklyn, New York, to my Jamaican parents. My mother was studying at NYU at the time. She was doing a master's in nutrition. My father, having met her in Jamaica 10 years before, decided to come to New York to marry her. He had just completed some education in England. That was typical for Jamaicans at the time. And he came to America, knocked on my mother's door, and I think a month after that, they were married. My brother and I, came shortly afterwards, and 11 months after I was born, my dad decided we're going back to Jamaica. So when I was growing up in Jamaica, we visited the US a lot, and you could get absolutely everything in the stores, like everything. And I thought, Dad, why did you take us back to Jamaica to grow up? Why? But I took a few things for granted. In Jamaica, I never thought my intellectual capacity was limited. Never occurred to me that there were any limits. So it was nothing for me to decide at age 7 that I wanted to be a doctor, because frankly, all the doctors around, or most of them, were Black anyway. Never thought of it. I was in a majority Black country. However, I also thought that, wow, I wanted to go back to the US for school because, after all, I was an American. So I did. When I get to University of Pennsylvania, something happened. I was not told directly, but somehow told that I didn't belong there. I was there only because of affirmative action. So this little girl who grew up thinking there was no limits to her intellectual capacity was now told, oh no, you don't deserve to be here. There are limits on your capacity. I thought it was unfair. When I went to medical school, I noticed on a slide that the infant mortality rate for a Black American baby was worse than a Jamaican baby and more than twice that for a white American baby. I thought, that doesn't make sense. I come from Jamaica. There is poverty. This America, which has everything, how could that even happen? It didn't make any sense to me. And I was told it was related to poverty. But I'm saying, there's poverty in Jamaica. We should not be better on that metric because there's more poverty. And I knew how great the US was in terms of resources, because after all, I was at Harvard and there were a lot of resources. Took me years to find out. And this, I'm going to share with you, is some of the things I found out about why the disparities exist. So today, we're going to talk about some of the maternal health disparities experienced by Black women in America. We're going to identify causes for the disparities and, importantly, some solutions to address these health disparities. So what are some of them? This is only a snapshot because almost every maternal health outcome, Black women have the worst metrics, followed in some cases by Native American women. In some cases, it is surpassed in Native American women, but mainly Black women have the worst outcomes in many metrics. So these are the maternal mortality rates in the US, 2021. As you can see, for Black American women, it was 69.9 per 100,000. If you look at the maternal mortality rate for a country like Grenada, a small country in the Caribbean, is less than 30 per 100,000. That doesn't make sense, does it? But when we look at the maternal mortality rates in the US in general, look at 2019 to 2021. It's getting worse for everyone, and particularly bad for Black women. This is another slide showing the trends. And look at Mississippi. This was 2017 to 2019, not 2021. So this shows the 65.1 was when in the rest of the country it was about 44 to 100,000 for Black women. So as we heard earlier, Mississippi is not doing very well in this metric. And let's look at infant mortality rates by race and ethnicity. And as you can see, again, for non-Hispanic Black women, it is worse than everybody else. And as I mentioned, this was the statistic that stood out for me. What's disappointing is that the disparity is about the same that it was when I was in medical school over 20 years ago. It might be a little better, but the disparity is the same after all these years. And for Mississippi, it's actually worse for everyone, and of course, worse, unfortunately, for Black women. How about preterm birth? Why preterm birth is a particularly disturbing outcome for women is because it's one of the highest reasons for infant mortality, preterm birth. And so as you can see, for non-Hispanic Black women, again, it's worse, 14.1%. That means 14 out of every 100 babies born, when we think about a percent, are born preterm, before their time. And in Mississippi, that number is 17.7. 17.7 of every 100 babies are born before their time. Low birth weight is another metric, and of course, that is also something that's pretty significant. Low birth weight means that a baby is born under 5.5 pounds. And low birth weight sets up a child for a lifetime of many cases, more illnesses than they would if they were born at normal birth weight. And also, it can even affect their educational attainment and their income level for the rest of their lives. That is what low birth weight can mean. Cesarean deliveries. When I talk to students, I often ask them, why do we think we do cesarean sections as obstetricians? I'm an obstetrician. Why do we do cesarean sections? We do them in theory, to save babies and protect mothers. However, we're not really doing that because it's worse for Black women, 35%. In Mississippi, that's about 40%. Interestingly, for Native Americans in Mississippi, it's about 47%. But are we protecting our mothers and our babies? Not so much, because cesarean sections are also associated with large complications and more associated maternal mortality than a vaginal delivery. I am not saying that we don't need cesarean sections. Some women do. I had to for both my children. But what I am saying is too many are being done and more than is needed to protect our mothers and our babies. And the result of that is that more of our mothers and our babies are dying prematurely. Preeclampsia. This was a study done out of New York. And what was interesting about that is the rates of preeclampsia was worse for Black women, and this was regardless of income level. So it wasn't poverty. It never really was just about poverty. I'm not saying poverty doesn't play a role, but it's not just about poverty. And fetal mortality, this is also known as stillbirth, that is death of a baby before baby is born, from 20 weeks to before the baby is born. And as you can see, as I mentioned, Black women are almost at the worst, but it's only surpassed by Native Hawaiian or other Pacific Islanders. So, the reasons for these health disparities, the reasons that it took me many, many years to learn, but I'm so glad I did. I'll start with implicit bias, and I want to explain why this is different from overt biases. When someone has an overt bias to us, hopefully we recognize that, we know, they state it clearly, and that is oppressive in itself. But the thing about implicit bias is that these are people, and we all have them, by the way, so we mean well, we think we're doing well, we really think we're being fair to everyone, we really think we're being equitable to everyone, but it's so deep inside that we're not. We don't realize that we're not being fair. We don't realize that we're not being equitable. And what does that result in? It results in Black people getting substandard care from people who know better because they don't realize they're doing that. They don't realize the biases in getting in the way. And healthcare professionals have the same level of implicit bias as everybody else. So we, who have a duty to take care of everyone with equity, are not doing that. The study that I mentioned at the bottom was particularly disturbing to me, and I do think it's evidence of implicit bias. This study was done in Florida, and they realized or discovered that Black newborns experience 430 more deaths per 100,000 live births than white newborns. But when cared for by Black physicians, the excess deaths dropped to 173 per 100,000. The Black physicians were no better than the white physicians in terms of qualifications, educations. They had no fewer patients. When they took care of white babies, there was no disparity. The only explanation, at least I could come up with, is probably implicit bias, because I certainly don't believe that any physician would knowingly not do the very best for their patients. And then the other thing is epigenetics. The disparity is not in our genes, but things can happen to how our genes is shown or displayed over generational. And that is what epigenetic is about, how we express certain things in our genes, and this can be passed from generation to generation. And what happens is that because of these changes, there are certain things that are programmed in us and programmed in our babies in the womb, and this can affect our baby's risk of disease later in life. And for example, the risk of mortality from ischemic heart disease is inversely related to the birth weight of residents, and this was done in UK. So what that means is that a low birth weight baby, and you know black women have the highest rates, a low birth weight baby already is more likely to have heart disease than a normal birth weight baby. And then there's a strong link between other chronic conditions like hypertension, coronary heart disease, type 2 diabetes. So when a baby is born low birth weight, from the beginning, that sets up the baby for a higher risk of health problems. It doesn't mean that it has to happen, but an uphill battle to reduce the risk. Weathering. This theory, and it's more than a theory now, was first proposed by Arlene Geronimus. What she noticed in the 1970s that she noticed that her young pregnant black women patients, this was teenage in a clinic, were having diseases that were affecting white women years later. And she wondered why this was happening. And she did a lot of research and work, and she recognized that black experienced early deterioration of health as a consequence of the cumulative impact of repeated experience with social or economic adversity and political marginalization. It affected the health, premature aging because of this. It was quantified as allostatic load, the wear and tear on the body, like that, wear and tear on the body, which accumulates over time after exposure to repeated or chronic stress. And this worse for black women, for white women, not explained by poverty. And non-poor black women between the ages of 55 and 64 years, 5 times more likely to have high scores compared to their white counterparts. And again, not poverty, because non-poor blacks more likely to have higher scores than poor whites. And the mean allostatic loads for blacks is similar to whites that are 10 years older. So this biological aging of 10 years in excess of chronological aging. So genetics, is it in the genes? That's one of the explanations that's often offered. Maybe it's genetics. Well, interestingly, infants born to women in Africa who come to America, so the women are from Africa and they come to America and they have their babies in America, have the most favorable birth outcomes. And then if someone grew up in Jamaica and comes to America, have her baby, then her birth outcomes are better than US-born black women. So, genes, maybe not. And studies have been done looking specifically at the areas in Africa where genetically are related to women in America. And when we look at that, and those women have babies in America, the birth outcome is better than US-born black women with similar genes. So, not so much. Genetics, does it play a role? Well, there's another thing that can happen to genes because of exposures and stressors. So telomeres are the protective tips at the ends of chromosomes, and short telomeres have been associated with more disease and poor survival. Black women ages 49 to 55 had shorter telomeres than white women, suggesting an approximate biological aging of 7.5 years. So these are 2 separate researchers. This is Dr. Elizabeth Blackburn, and I mentioned Dr. Arlene Geronimus. Interestingly, it's almost the same finding. This biological aging in process of chronological aging affecting the health of Black women. And you're going to hear much more of this, but adverse childhood experiences, stressful or traumatic events, including abuse and neglect. They may also include household dysfunctions, such as witnessing domestic violence or growing up with family members who've had substance use disorders. And so what happens is the more adverse childhood experiences, then you have increased risk of poor health. So increased risk of being less physically active, being overweight or obese, more risk of smoking, alcohol use, health, cancer, heart disease, respiratory disease, and even more risk of sexual risk-taking, mental health, problematic alcohol use, and even more risk of drug use and interpersonal and self-directed violence. And the prevalence of ACE is highest among Black, non-Hispanic children across the United States. What makes these events an experience? The thing is, bad things happen, and bad things can happen to everyone. The problem is, if you don't get the mental health support to cope with it, then it becomes an experience that affects you for the rest of your life, and you have to overcome it, fight it. And that is another thing that affects the health of women, Black women, going into pregnancy. So we see that not only do Black women go into pregnancy sicker because of all the reasons I discussed, not their fault, obviously, but because of all the reasons they discussed, but when they come into pregnancy sicker, they don't get the help they need or deserve. And here we have that vicious cycle. We're not helping to correct some of those health disparities before pregnancy, which we need to do. And women come into pregnancy with these health disparities, they don't get the extra support they need so that they can be healthy in pregnancy. And that extra support is causing unnecessary loss of life. When this Department of Health, and I love quality review committees, and Mississippi has one, because why it is a beautiful thing, and you hear more later, is because we recognize that, guess what? More than 80% of these deaths could be prevented. Because they look at it, they examine it, and they find that in some cases, 80%, some cases 90%, some cases 100%. We are not saving mothers who we could save. We are not doing our best. I'm an obstetrician, so I know that life-threatening things happen. I know sometimes there's things we can't do some things about, but 80% of the time, 90% of the time, in some cases 100% of the time, that is unacceptable. That is unacceptable. And what are Black women in Mississippi dying from? Cardiomyopathy and cardiovascular disease. Because guess what? Come into pregnancy with your increased risk of hypertension, or you get hypertension earlier than you should, or get it at any time. And guess what? If you don't have care before pregnancy because the insurance doesn't cover it, or you don't get insurance before pregnancy, how can you take care of it? And then if you come into pregnancy and people say, no, that's okay, you don't have to worry about that blood pressure, but it's killing you, then it can kill you. In my book, I wrote about Shalon Irving. She was a double PhD person who lived in Atlanta. She died after childbirth because they say of complications of hypertension. The interesting thing about Dr. Shalon Irving, she saw healthcare providers 5 times before she died. 5 times. And then the last time they said, just give it more time. And she collapsed later that evening. That is what happens when you go in with a health condition and you do not get the attention you need. That is unacceptable. What can we do? Because we can do something about this. Training to counteract implicit bias is one thing. And I'm not suggesting that every training works, because frankly, it does not. People need to care about it. And if someone gets trained and it's just checking a box and they don't care, well, it may not work. But if we care about improving the care that we deliver, if we care about how we interact with people, if we care about fairness, then we will care about learning what we can to treat people fairly as clinicians and even as non-clinicians. And people who cared had the best outcome from only 45 minutes of training, and they saw that 12 weeks after. So if we care about doing better for patients and doing better for fellow neighbors, we can do better. We do need to increase the support for African American women during pregnancy and childbirth. And doulas is one great way to do that, because doula-assisted mothers were 4 times less likely to have a low birth weight baby. 4 times less likely. Think about the trajectory of that baby when that baby goes from being a low birth weight baby to full-term birth weight baby. Think about that reduced risk of all those diseases I talked to you about, all those health conditions I talked to you about earlier. And 2 times less likely to experience a birth complication. And if you don't experience a birth complication, then you have a lower risk of dying and having a bad outcome. Doulas are another excellent solution. This solution I'm particularly excited about for different reasons, but group prenatal care. The beauty of group prenatal care is that, yes, women get their individual checks, but then they get an hour and a half or so of education to take care of themselves through the pregnancy, education so they can understand risk, and education that they can be partners in their care. Group prenatal showed a reduction in preterm birth from 15.8% to 10% for African American women in a study done at Emory and Yale. This was done back in 2007. About 80% of the participants were Black, and they were late teens to early 20s. Some of the same researchers did this study again in 2017, and they did it in Detroit and Nashville. And what they found, that they brought the preterm birth rate from about 15% to 6.4%. So think about, if we can reduce preterm birth in that way, think about what that means for babies. Lower infant mortality rate, because preterm birth is a big driver of infant mortality. Think about that trajectory of health for those babies, because preterm birth is associated with a lot of health conditions for some of our babies. Think about that. We set our babies up better from the beginning. Breastfeeding was higher, and breastfeeding has benefits for both mom and baby. Think about the improvements in health for both our moms and our babies when we are able to support breastfeeding better. And there was no difference in cost. In the small print, but not to de-emphasize it, lifestyle medicine. I'm a big advocate of lifestyle medicine as well, and because it has been shown to reduce chronic diseases and in some cases reverse it. They've applied it to coronary artery disease, they've applied it to prostate cancer and had great outcome. And exercise in pregnancy reduces the risk of chronic disease for both mother and child. There's evidence for that. Early research that mindfulness-based intervention can be beneficial for outcomes such as anxiety, depression, and perceived stress. So think about being able to approach pregnancy with less stress. Excellent, because it's a stressful time, and particularly stressful for Black women because they know the statistics. Think about if we can reduce that stress with support. And healthy dietary patterns can reduce the risk of preterm birth. If we support women with their diet and not just say, oh, go eat that, that's not good enough. Because if we say, go eat that, and women cannot access those foods, we're not helping them. We give women access to healthy foods. And guess what? We also show women how to prepare these healthy foods so that they actually can implement. Not just go do it, show women how to do it and give them the resources so they can do it. Give them the support they need. So I wrote more about this in my book. Dr. Beatty said, show the book, but Pregnant While Black, because of my journey to try to explain more about why this is happening, give you some real stories that is happening to women, and share what can be done, what we all can do to improve the health of Black women in pregnancy and beyond, improve the health of Black children for their whole lives. We can do this if we want to. We can do this if we care. We can do this if we really mean it when we want to reduce or eliminate disparities. I totally believe it's possible. It will take time, investment, care, commitment, but I totally believe that we can do this with this investment of time, love, energy, and commitment. And even though Dr. Martin Luther King said this in the 1960s, it is still too true today. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. We cannot expect that if all the disadvantage that Black women experience, not because of their fault, that they can just catch up by themselves and have a healthy pregnancy, a healthy life. Black women need to be supported before pregnancy, throughout pregnancy, and beyond. And with a better start, babies can do better and have a better life from the very beginning. Thank you.
Folks coming up. To get us started, I'll ask a question. So, one, thank you so much for what you shared, and I really appreciated the beginning of your talk when you talked about and mentioned that the maternal mortality rate in Jamaica,
Well, the infant mortality
rate in Jamaica was much higher in the U.S. despite the larger experiences of poverty in that country. And you also talked about this idea of weathering and
Yes.
the differences because of weathering. Can you put Jamaica in context in relation to the United States with regards to weathering? So, for example, what are the experiences that Black women might be experiencing in Jamaica that are very different from what we experience here in the United States?
Sure. So it was the infant mortality rate because, to be quite honest, Jamaica isn't doing the best in maternal mortality, and that is actually due to poverty and resources. So the difference is, I would say that poverty, yes, can be hard on anyone, anywhere, and it is definitely a factor in Jamaica as it is in America. The difference in America is that it's not just poverty. Poverty is bad. Poverty can affect health, but in America, it's not just poverty. It is poverty and the stresses related to racism, the stresses of always having to prove yourself as a Black woman, the stresses of always feeling the pain of people thinking that you're less than, the stresses of always having to explain yourself. That is something that in general we don't have in Jamaica. We don't have that. So there's a stress of poverty, but there's not these additional stresses that play on your health. And then when you get to the institution that you should be cared for, the stress of knowing that you may tell your healthcare clinician, there's something wrong. And they're telling you it's just in your head. Or they're telling you, don't worry about it. Then you get refused that stress. And for some women, it's too much, meaning the condition beats them and they don't make it. Some women, they have complications. Some women, it results in trauma from having life-threatening illness when they said, help me, and they didn't get the help. In Jamaica, some of the disparities are related, of course, to poverty and not having access at the same time.
Absolutely. Thank you. Any questions from anyone else from the audience? I have plenty. Okay, go ahead.
Hello.
Hello.
Yes, I said yellow for those not Jamaican. And I can teach, you can say Manning, which is another one, but I won't keep going. I'm Dr. Hernandez from Jackson State University School of Social Work. Um, I've been teaching policy and research methods for a long time. And not to go on a very long speech, but then I saw on TV, I don't know if you have heard of a young medical student, Joel Burbell, I think. So he was pointing out that something as simple as a pulse oximeter, well, you know where I'm going. So do you want to, after I finish the question, you may want to explain what's the deal with the pulse oximeter with people of color. But are there any other sort of issues that, or devices, or for instance, one thing I taught is that, and I can't remember the year, like a lot of medications have been tested on, let me back up the historical part. The medical profession or science noticed that women were being overdosed, right, with medication. And to make a long story short, it's because those medications were tested on men. So from that perspective of sort of designing the whole system gears to, well, lighter people, what experiences besides the two that I mentioned, are there more related to women of color being misdiagnosed, overdiagnosed, underdiagnosed? And sorry, explain the oximeter, because you probably can do it better than I.
I think you did great. Thank you for the question. Okay. So Joel Burvell is a superstar medical student who does TikTok videos to raise awareness on health disparities. And one thing he showed is that what happened is when people of color wear pulse oximeters that measure your oxygen level, it overestimates the oxygenation. And the problem with that is that when COVID happened, for example, pulse oximeter was something that you used to determine should somebody stay in the hospital or go home, are they fine? And so if the number is higher than it should be, guess what? Someone who shouldn't be sent home gets sent home. And sometimes they get sent home to die when being in the hospital, they could have gotten the oxygen and the support they needed. So that is the pulse oximeter. They've also noticed that with kidney function. So they used to have it, and this is all over medicine, right? We were taught that you need to correct kidney function for Black people, or that is different. And this was institutionalized. And what they discovered is that, so they overestimated the function, the kidney function of Black people. So what that means is that when you overestimate something like that, when you have, as a Black person, poor kidney function, you're not getting the treatment you need fast enough to reduce the damage, and guess what? That leads to more end-stage renal failure before or when it could have been avoided. So some of the disparities. In Black women and maternal health disparities, one of those disparities were VBAC calculator. That's a vaginal birth after cesarean section. So what they did is they put Black women into the calculator, which means that putting that in there made the physician or the clinician think that the woman had a lower chance of having a vaginal birth after cesarean section baked in. So that is how some of this is baked in to the system in terms of these disparities. I'm not sure if I answered, and he stepped away, all your questions. Was there another part to the question too? Yeah, the VBAC calculator. So in terms of, I find that in pregnancy, when you look at the data, you ask about over-treatment and under-treatment. Is under-treatment. No, you're stressing yourself out. That blood pressure isn't real. It's just you stressing yourself out. Under-treatment, what I find. And yes, the research does not represent people adequately, and so we're using metrics that are based on not black women to treat black women, or metrics that are artificially changed for black people and treating black people under-treating because of certain metrics.
Good morning. I'm Valisa Davis with the Mississippi State Department of Health, writer for the Title V Block Grant. Question, you mentioned doulas. Can you give us a little feedback on the relationship between doulas and the physician staff within the hospital setting? I know across most states that is not the most amicable relationships. and I just came back from the AMCHIP conference yesterday, as a matter of fact, in Oakland. And I know California actually funds doulas. They've incorporated where they get $3,000 for each patient. That is an anomaly. But can you give us a little more feedback about how physicians and doulas can more solidify their relationships to support families?
Sure. So let me talk a little bit about my experience with doulas. When I first heard of doulas, I, as a physician, like buying into how physicians think, I thought, oh, they're coming to interfere. I really thought, I'm so embarrassed to admit it, but I thought it's good to share that, right? So what doulas do, they're not coming to interfere. Doulas are coming to support black women, be an advocate for black women or women in general. And so why that is important is because physicians are certainly not perfect. Women in their pregnancy, in their state, in their level, cannot speak for themselves. They need somebody to support, somebody speak for themselves, speak for them, because they cannot speak for themselves. So this relationship, how we can improve it, I think, is probably maybe having more social and mixers between doulas and physicians so that they can understand the role of the doulas, understand that it's not team one, team two, it's the same team to get the best outcome, because physicians do want the best outcomes for the babies and the mothers. And if you have more people on your team, it's a win. It's not a negative. And I think probably more education will help people know that it's more a win. It's not a competition at all. It's his support. They're not trying to do the job of physicians or midwives. They're just trying to support the mothers as best they can. And unfortunately, because of all the dynamics, they may have to fight to do this, which it shouldn't be, right? It shouldn't be, but you know, that happens. You're welcome.
Any additional questions from the, here we go. Thank you.
That was a great presentation, Dr. Rainford. You mentioned that a lot of the causes of death are cardiomyopathy with pregnant mothers postpartum. How can we incorporate or advocate for more screening guidelines for mothers experiencing postpartum cardiomyopathy?
Yeah. First, we want to get mothers into pregnancy healthier. And I know Mississippi is working or expanded some Medicaid measures. So Medicaid pre-pregnancy would be a great thing. So we can kind of screen before. Second, during the pregnancy, we control blood pressure better. So even the literature is showing that better control is better for outcome. We used to say, oh, you know, if it's less than 140/90, or if it's between 140/90 to 170/110, it's okay. No, we need to control better during pregnancy. And we as clinicians need to be aware that that control is needed and be aware of the literature so that we can control that. And then you asked about postpartum support. We need earlier visits. We need that 2 to 3 weeks postpartum that ACOG is advocating. If you have high blood pressure during the delivery process, you need that visit much earlier. Home blood pressure cuffs that you know how to use, who to call if there's a problem, and then you get more support that you can be controlled after the delivery and well beyond. And if a woman has swelling after pregnancy, that's all of a sudden, and shortness of breath, you don't tell her, oh, that's normal. You work it up, you look it up. That's what Dr. Shalon Irving had, swelling, feeling not well, and they said, oh, it's okay. She probably was having something related to cardiomyopathy. I don't know, so I'm just saying that. But, you know, she died. She died. So we do need to address that. And as you probably know or will know, that when you have something like cardiomyopathy, your blood pressure needs even tighter control than if you don't have it. So it's just so important. So in terms of advocacy, I think everybody has a voice. You're going to have a great role later on advocating policy changes so that we can have more coverage and clinician education so that we all know that we need to treat it much more aggressively than we have been. Does that answer your question?
Any additional questions from the audience? This has been a rich conversation. Thank you so much, Dr. Rainford, for your expertise and for sharing with us. Let's give her a hand for all she shared.